Thank you to our conference organizers to give the floor to an epidemiologist who survived professionally in France, thanks to the support of FOMINDEP. It is a self-funded association of health professionals and citizens that advocates for transparency in medical information and education, and for freedom from interests other than those of patients. The aim of this presentation is to provide incentives for changing practices in order to avoid breast cancer overdiagnosis. The appraisal of side effects due to overtreatment by radiotherapy is intended to contribute to turn physician in title into physician in reality, according to Hippocrates' wording. It is also a key information for the women comparing benefits and harms before deciding to undergo or not to undergo mammography screening. Since year 2002, Article 26 of the French health law had been mentioning that a health professional who speaks publicly must declare his potential conflicts of interest. This intent for improving transparency did not cost too much to Bernard Kouchner, who was the ministry who launched the law. There was no decree implementing the requirement of Article 26 in France up to 2007, when FOMINDEP obtained it from the French government. Evidence of similar breast cancer mortality and evidence of overdiagnosis provided by the most reliable randomized controlled trials on mammography screening did not close the debate over the deductive Hallstedian model versus an inductive approach leading to a systemic model of breast cancer. The first part of this presentation justifies the use of an empirical approach for estimating overdiagnosis. This presentation will then focus on the investigation of the French epidemic of apparent breast cancer from year 1980 up to 2010. It provided estimates of the current yearly incidence of overdiagnosed breast cancer. Most overdiagnosed women underwent radiotherapy. Estimate of fatal cardiac failure and of cancer of other sites attributable to radiotherapy were obtained by attributable risks from published results on large cohorts of women treated for breast cancer in France. The conclusion will raise some questions for further research. The inductive approach is empirical. In 1850, in the 19th century, when exploring the contribution of pathology to cancer diagnosis, Broca raised a fundamental question about the reliability of the biopsy for diagnosing progressive cancer disease. In the introduction of his report, he stated that histology cannot predict the progression of a tumor. However, training in medical faculties was influenced by the Hallstedian model. Without treatment, breast cancer would inevitably extend locally from malignant cells, spread to surrounding tissue, to lymph nodes, and finally killed by distant metastases in vital organs. This model supported secondary prevention, that is, early detection and treatment of the tumor before it would spread and become symptomatic. Use of secondary prevention in medical practice postulates the reliability of testing for a progressive cancer with biopsy. This deductive approach was supported by the perception of increasing cure due to early diagnosis and treatment, even after that pathologists like McKinnon alerted again 100 years later about the limitations of the biopsy to predict the dynamic of a tumor. Paul Broca won the Portal Prize for his 600 pages report. This was in the middle of the 19th century. The first part was entitled Malignant Tumors. The second part was entitled Pseudocancer. In 1852, Lebert published an 800 pages book about cancer disease and curable disease confused with cancer. More recently, autopsy studies with systematic biopsies in the breast yielded more invasive and much more ductal cancer in situ than expected from registry data. According to distinguished experts, including Bernard Fisher, the reliability of the biopsy for taking decision in cancer management might be compared to the faithfulness of what you would imagine that follows in a film from a snapshot. Here is a published graphical representation of time trend of breast cancer incidence and breast cancer mortality in France. The deductive interpretation was the following. Increase in incidence over time resulted from environmental factors and to a longer lead time due to earlier diagnosis. Time trend in breast cancer mortality would then result from increasing successful treatment of earlier diagnosed tumors. This interpretation was supported intuitively by clinical studies showing that screened patients had better survival. The discrepancy between incidence and mortality observed in year 1980 was mainly attributable to breast self-examination. You see this huge difference between mortality and morbidity. Mammography screening strengthened the difference between incidence and mortality during subsequent years. The inductive approach provided a different interpretation. Time trend of better survival was due to increase in overdiagnosed cases. This resulted from lower specificity of the biopsy following breast self-examination and/or mammography screening. Lower case fatality rate was observed among women diagnosed with breast cancer who practiced breast self-examination. But large comparative studies provided evidence that screening by breast self-examination did not modify the risk of breast cancer death in the population. The failure of breast self-examination for reducing the mortality due to breast cancer in the population should have already pointed towards overdiagnosis. Overdiagnosis would explain why observed survival was longer among women practicing breast self-examination and diagnosed with breast cancer. Overdiagnosis case increased survival because they did not die from breast cancer. Another explanation of the better survival of women diagnosed when practicing breast self-examination was the lead time due to earlier diagnosis. Deductive models made use of lead time for explaining discrepancies in time and space distribution of breast cancer morbidity. Changes in lead time distribution when improving the sensitivity of tumor detection by mammography screening resulted in prevalent cases considered as correctly diagnosed. Speculative assumptions about lead time of 4 years or more and faithfulness to a real increase in breast cancer incidence over time precluded the possibility to get a fair appraisal of overdiagnosis. Last year, Zahl and colleague Peter Jørgensen published a key paper in the British Journal of Cancer. It will be available free of charge next October, 2 weeks from now. This paper provided evidence that clinically relevant lead time in screened cohorts was about 1 year. It only explained a fraction of observed prevalent cases. Actually, lower specificity of the biopsy following mammography screening yielded overdiagnosed cases among observed prevalent cases. Our concern today is more serious for women than Galileo's view about respective movements of Sun and Earth in the universe. Last year, the paper by Zahl and colleagues who published the quantification of clinically relevant lead time observed in Norway, where opportunistic screening was unlikely, corrected errors in the deductive models minimizing overdiagnosis by making use of inflated lead time. Our colleagues were dealing with a major concern. 1 year after Galileo provided evidence-based correction of wrong models, this was in 1611, he was welcomed as a hero in Rome. Let us, on our term, warmly applaud Per Henrik Vinus to this conference in Oxford. Thank you. Now you are ready to face the disaster due to screening of breast cancer in France. Empirical investigation of an epidemic was best taught by Alexander Langmuir at the Centers for Control Disease. His inductive approach used to take the big picture before interpreting observed facts. Here is the conventional way to provide epidemic curves, crude numbers of new cases per year. Each pair of columns provides the yearly number observed every fifth year, both for cause-specific death and diagnosis. For lung cancer, screening was not a common practice in France. Lung cancer diagnosis and death due to lung cancer were highly correlated. There were about 12,000 more lung cancer deaths in 2010 than in 1980. They were mainly attributable to increasing tobacco consumption during previous decades. For breast cancer and for prostate cancer, death occurrence did not change much. For breast cancer, occurrence of diagnosis was already much higher than death in 1980. As mentioned, previously overdiagnosis due to breast self-examination might explain such a large difference. Since 1980, mammography screening and PSA had been increasing in France. There were about 30,000 more invasive breast cancer diagnoses and 45,000 more diagnoses of prostate cancer in 2010 than in 1980. For breast and for prostate, the increase in screening was correlated with higher discrepancies between diagnosis and death frequency. This was mainly reflecting overdiagnosis. There was not only a discrepancy between breast cancer incidence and breast cancer mortality. 4 French registries published the time trend of early and late-stage breast cancer incidence. Incidence of late-stage diagnosis did not change substantially, whereas incidence of early stage increased with increasing screening. According to this result, increase in breast cancer incidence would be mainly attributable to overdiagnosis among early-stage tumors. The computation of overdiagnosed breast cancer among women aged 35 or more in 2010 made use of available data before mammography screening was common in France. Incidence of clinically relevant cases was estimated from the data available in 1980. Then, age-specific incidence rates of clinically relevant cases were applied to women aged 35 or more in 2010. The difference between the observed incidence case and the expected number of clinically relevant cases in 2010 provided the estimate of the overdiagnosed breast cancer cases we were looking for. 3 background data are provided here before estimating the number of clinically relevant cases. The risk of death due to any cause was declining strongly from 1980 to 2010 in France. It was 34% lower in 2010 than in 1980. But the risk of death due to breast cancer did not change as much. It was 6% lower in 2010 than in 1980. This decline might be explained by treatment improvements. It does not support the hypothesis of an increase in incidence of clinically relevant cases. The last background data give an appraisal of the increase in the practice of mammography in France. In 2000, there were about 8 times more mammography machines working than in 1980. Let us come now to the question, the fundamental question. What was the incidence of clinically relevant tumors according to age in 1980? This slide shows the discrepancy between breast cancer incidence and breast cancer mortality by age in 1980. As mentioned previously, breast self-examination was common in France. It contributed to overdiagnosis due to the lack of specificity of the biopsy. The age-specific incidence of clinically relevant breast cancer should actually lie somewhere between the curves of breast cancer incidence, the red one, and of breast cancer mortality, the blue one. The breast cancer incidence curve gives us a standardized rate of 152 per 100,000. The minimum rate of clinically significant tumors would be the breast cancer mortality rate in 1980, corrected for the age distribution in 2010, that is 65 per 100,000. The truth should lie somewhere between the two. A geometric mean was used for getting the incidence of clinically relevant tumors. It amounted to 102 per 100,000. The detailed result obtained for clinically relevant tumors, overdiagnosed invasive breast cancer and overdiagnosed ductal carcinoma in situ, appears on this slide. Among women aged 35 or more, 28,932 diagnoses of invasive breast cancer were found overdiagnosed. That is 60% of the 48,301 observed invasive breast cancer cases in 2010. Increase in ductal carcinoma in situ from 1980 to 2010 was also considered as overdiagnosis in 2010. The grand total of overdiagnosed cases in 2010 amounted to 36,597. Oh, I am wrong somewhere. No. According to previously published data, about 80% of patients diagnosed with breast cancer were treated by radiotherapy. When applying this proportion to overdiagnosed cases in 2010, the total new cases overtreated by radiotherapy was close to 30,000. Result of long-term of cardiovascular death attributable to radiotherapy in France were published in 2011. According to these results, radiotherapy of overdiagnosed women in 2010 would produce 843 deaths from cardiovascular disease within the next 30 years. Another study provided attributable risk of new primary tumors attributable to radiotherapy. The number of such tumors for sites other than breast would amount to 214 during the 10.5 years following overtreatment by radiotherapy in 2010, that is up to 2020. These cancer cases, the short summary you have mentions 169. These cancer cases were restricted to invasive overdiagnosed cancer. The 214 takes into account the cancer in situ. Sure, results obtained were unacceptable or unconscionable. However, the hypotheses were very limited. Same age-specific incidence of progressive cancer in 2010 as in 1980, and incidence of true progressive tumors somewhere between breast cancer mortality rate and incidence rate in 1980. When looking for progress in cancer management, the question raised by the result is how to improve criteria for defining breast cancer. Here is a proposed answer. Why should we not investigate Broca's recommendation in 1850? Observe the dynamic of the suspected tumor before deciding to biopsy or not. A workshop will start at 11 a.m. in room L6 to build the study within screening programs. Thank you for your attention.
Thank you very much. There's a lot to discuss in that. Please, questions, comments? I'll come, folks. Yes. Wait.
Thank you very much for the second working up the people. That's the next step. But I absolutely agree. I'm a told this program, you told the audience here. So when we overdiagnose, yes, we usually try to do it every day. Because we didn't teach you, we didn't teach you because we didn't teach you. So we know what's after overdiagnosis, we know what's after overdiagnosis. We at the end of the day, diagnosis. So I get to know difference why sensitive management for breast cancer cannot be seen even ethically or clinically technically because mostly pointers with the sample done the 10 years ago with the strategy to suggest conservative management of down to maybe 3 management patients with very close to cancer. And breast cancer should be the same method so that it's strong important to control the environment and itself.
Yeah.
Yes. The catastrophic result of about 843 deaths due to radiotherapy was based on the traditional way, the conventional way to apply very aggressive treatment to breast tumors. And as you evoked that, aggressiveness has been changing a lot since 50 years when Bernard Fisher proposed to change Hallstett's intervention into some more respectful intervention with respect to the breast of the woman. I am pretty sure that there is now a trend in order to reduce the aggressivity of the medical practices, also in France. But there is a terrible problem due to the impossibility to understand how to move on with more appropriate interventions, given that we mix up through progressive cancer with non-progressive cancer. This is called in epidemiology misclassification. And this situation is very serious, and only research can help the fundamental issue, which will not be just to reduce our aggressivity, but to better understand what to do or not to do.
Thank you. Clint. Mike down here.
Thank you for a wonderful review, which was, in my head anyway, very complicated and difficult to assimilate, but I'll try harder when I can get hold of the written paper. I'd like to know very much, though, what women in France know about overdiagnosis associated with mammography, if anything, and do they get informed routinely about the possibility or the downsides, the harms of mammography or not?
Thank you for this very nice question about information of women. The consumers in France have been very well aware of the problem, more especially because there was a translation of Welsh's book, Should I Be Tested for Cancer? Maybe not, and that is why. This book was translated in French in 2005 or 6, and there was an introduction by the Surgeon General. And William Dabb, who was in charge of doing it, made some reference to the conflict between the technical approach and the real need of healthcare of the population. Then there was a book published by a very courageous woman. Her name is Rachel Camperg, and the title of the book is No Mammo with the question mark. And this helped a lot, and there were some very good papers in Le Monde or in monthly reports about science for the general population in France. However, the politics of screening did not change anything to the priority of mammography screening in France.
Perhaps that's...
Peter speaks in this conference. Thank you, Peter.
Almost 20 languages, including those working at families and doctoring and Arabic and so on. And this is because people are very all over the world by the fact that women are temporized to an extent that I have now started to talk about sexist women. And try to be able to get full information while females don't. It's outrageous.
I'm not very good at statistics. Would you mind going back to where you did your calculations? If you revert to your slides, I think there was a very questionable assumption that you made.
Do you want the assumptions here?
One more.
Yeah.
So it's where you calculate the geographic link between the number seen and the number and mortality.
Incidence and mortality, yeah?
Yes. Now,
thank you.
52 incidence, 65 mortality. How did you make your classification to that assumption that that would be to be calculated on a geographic, on a logarithmic mean between the two? Somewhere between the two. If it were 100, if it were overdiagnosis that was close to 50 or 30 or 10, then the number of deaths killed by radiotherapy would be reduced by 50%, 70%, 90%. So I think my question is, where does that assumption come from?
Okay. Thank you very much for asking this question. I should come here, I'm sorry. The fundamental issue is the curability of cancer. This was a question raised in 1845, 5 years before the report of Broca. At that time, the Academy of Medicine in France raise the question, can we cure cancer or can we not cure cancer? And Broca's report was published except the 300 pages about pseudo-cancer, because there were already some manipulations of the surgeons who did not want that to question the possibility to cure cancer would be raised by pseudo-cancer. And what I do there is to be provocative with respect to other approach which do not question the curability of our interventions. And in my opinion, this way of being more aggressive, remember the last slide, with the teeth of the ostrich facing overdiagnosis, would be an incentive to have a new randomized controlled trial, to have groups with or without a biopsy, which can then compare if we have a real difference or not. I think that we made progresses for tumors which are sensitive to estrogens. We made a lot of progress for all what has to do with the systemic approach of breast cancer. There are also metabolic phenomena and so on. We know much more about a lot of ways to be efficient. But the traditional intervention, which is surgery, which is radiotherapy, is questionable in most instances. And this is why I adopted a mean point somewhere. I could have used another mean, but something in between. Yeah. This was to question the curability of cancer.
I think there is a lot more discussion to be had, but let's have it over coffee. Thank you very much, everybody, and thank you all.